Hello, my name is Betz, and this is my capstone project of increasing HPV vaccine compliance in family practice. Through Maryville University, my project chair is Dr. Maria Snell. Introduction, background, and significance. There is an increasing rate of human papillomavirus or HPV-related cancers and ailments overall each year. The HPV vaccine has been shown to be an effective method for preventing multiple cancers, but is vastly underused. Increasing HPV vaccine compliance will reduce the number of vaccine-preventable HPV-associated cancers, and providers discussing and recommending the HPV vaccine in family practice will hopefully significantly improve compliance rates and save lives. Problem statement. Providers are not recommending the HPV vaccine enough, therefore compliance rates for the HPV vaccine are not where they should be. From 2013 to 2018, a percentage of women who ever received one or more doses of the HPV vaccine increased from 36.8% in 2013 to 53.6% in 2018. The percentage of men more than tripled from 7.7% to 27%, but those rates do need to increase. Purpose of this project. The purpose of this project is educate providers on barriers in family practice setting for recommending and implementing the HPV vaccine. The overall aim is to improve providers' confidence in discussing HPV and recommending the vaccine to potentially improve vaccination compliance rates. Literature review. An annual average of 34,800 cancers were reported that were attributable to HPV from 2012 to 2016. Of the 34,800 cases, 92 were attributable to HPV strains that were covered in the HPV vaccines. 92% of those cancer cases could have been prevented had they have gotten the HPV vaccine. Providers recommending the HPV vaccine can drastically improve these vaccination compliance rates. Review of literature. There were three major themes in my literature review, and they were safety and benefits, knowledge, and barriers. So, safety and benefits. The safety and long-term effectiveness has been proven by almost 90 million doses being distributed since 2006 when it was approved by the FDA. The most serious side effect included headache, nausea, vomiting, fever, and a rare anaphylactic reaction. Long-term effectiveness is still being monitored, but there is no evidence of weakened protection over time. Knowledge. There is over 120 strains of HPV identified. Almost all of them can cause skin warts, but roughly 40 strains are classified as high or low risk. High-risk strains are associated with cancer, while low risk are associated with benign cervical cell abnormalities, genital warts, or laryngeal papillomas. HPV is associated with almost all cervical cancers and some vaginal, vulvar, penile, anal, and oropharyngeal cancers. The majority of the HPV-associated cancers could have been prevented had they gotten the HPV 9 variant vaccine. To improve compliance rates, our knowledge of facilitators and evidence-based reasoning has to also improve. Being knowledgeable on these topics enough to educate patients and parents as well. Utilize every resource and opportunity to verbalize his recommendations of the HPV vaccine. Can also increase compliance rates. Healthcare providers are actually, their recommendations are huge factors in the decision to receive the HPV vaccine. When a healthcare provider does recommend the vaccine series, it increases the likelihood of getting and initiating that vaccine series by 5 times. Some barriers to the vaccine. Vaccines in general face multiple barriers in compliance, including concerns for safety, vaccine misinformation, stigma, hesitancy, and distrust in healthcare facilities, and just a general lack of knowledge. The HPV vaccine encounters all those barriers surrounding just vaccines in general, and the fact that HPV is a sexually transmitted infection. These barriers are morally and ethically sensitive and honestly uncomfortable to sometimes bring up and talk about. Sometimes some people, especially parents, can think that the vaccine can affect sexual behavior or provide a perceived protection against these things when that's untrue. Barriers not directly concerning HPV vaccine include healthcare practices, limited staffing, the fact that the HPV vaccine is actually a very expensive vaccine and insurances sometimes don't completely cover 100% of it, and then it ends up costing, especially if they're over the age of 18, ends up costing them quite a bit of money. Design and methodology. So this was a quantitative exploratory design, and for the study was utilized through a pre and a post survey to evaluate changes in providers' confidence in recommending the vaccine and discussing HPV and the vaccine with their patients, as well as 2 months following the educational intervention. It's designed to effect a practice change for improvement in vaccine compliance rates. Setting. The setting of this capstone project took place in an adult primary care clinic in the Midwest region of the United States. 7 providers practiced there, with 5 participating in this project. The 5 were 3 MDs and 2 advanced practice RNs. Each provider saw roughly 10 to 25 adult patients a day. Providers distributed packets to patients who were 18 to 26 years of age, had not completed the HPV vaccine series yet or not initiated it, and they had discussed HPV and the HPV vaccine during their clinic visit with their provider. This packet included a anonymous patient survey, an implied consent form, locations where to receive the HPV vaccine with cost information, and a return envelope with prepaid postage and return label to the clinic. I received 26 surveys back to the clinic. Sources of data. So I actually had 2 different sources of data. The provider surveys. Provider surveys were a pre and a post survey for providers to evaluate changes in confidence levels in discussing and recommending the HPV vaccine series and HPV. Questions for providers. The pre and post survey measured confidence levels using a total scores from a 5-point Likert scale, ranging from strongly disagree to strongly agree. The Likert scale is a 5-point scale that allows participants to express how much they agree or disagree with a statement. This also includes the final survey. They were all the same. The survey included these statements where they would select strongly disagree to strongly agree. I'm confident in recommending the HPV vaccine series as a part of routine care for all eligible patients. I'm confident in discussing the different types of HPV and how their disease pathways are associated and their pathway associations differ with all my patients. I'm confident in discussing how HPV is transmitted with my patients, and I'm confident in recommending the HPV vaccine series to males as a part of my routine care, and I'm confident in that I can react effectively to a patient if he or she is hesitant to accept or initiate the HPV vaccine series. The other source of data was my patient surveys. So providers distributed the packets to patients, as I mentioned earlier, who were 18 to 26, had not started or completed the HPV vaccine series, had discussed HPV and the HPV vaccine with their provider. The anonymous patient surveys included 4 closed-ended questions and 1 open-ended question, and these asked what gender the patient identified as, and then they were given male, female, and other. If they were more likely to initiate the HPV vaccine after discussing with their provider, why or why not. If the discussion with their healthcare provider changed their views on HPV and the vaccine, and if the patient understood the information that they gave them regarding HPV and the HPV vaccine. So statistical tests for the provider surveys, I collected the data to evaluate the provider's confidence levels after the educational in-service. I was analyzed using a one-way repeated measures analysis of variance. The pre, post, and final surveys used total independent scores. The one-way repeated measures analysis of variance analyzed each set of data measuring the total Likert score from the pre, post, and final surveys 2 months following the educational in-service. The patient surveys were mainly used as descriptive data to support the provider survey results. So the results of the provider surveys, there were 3 measures of dependent variables, a pre, post, and final survey for each of the 5 providers that participated. The table shows the difference, how there's no difference in the mean score from the pre-survey to the post-survey, but what it does show is an increase in mean from 29.2 to 29.6 in provider confidence levels between the beginning of the project in June to the end of the project in August. It also shows that there's a significant decrease in standard deviation from the post-survey to the final survey. The results show that there was an increase in provider confidence in discussing HPV and the HPV vaccine after the educational in-service 2 months following. So the results of my patient surveys, as I said, that they were more descriptive to support the provider surveys, and I did have 26 returned surveys to the clinic. 18 were female and 8 were male. Some key points in this were 88% of patients were more likely to initiate the HPV vaccine after discussing with their provider. 81% of patients stated that discussing the HPV vaccine and HPV with their provider changed their views on the subject. And 100% of patients understood the information given to them by their providers. So the interpreted results, there was a decrease in standard deviation from the pre-survey to the final survey, but there was no statistical significance between pre and post after the educational in-service, since the scores were equal in standard deviation of 1.304. It didn't change. The standard deviation did change, as I said, from the pre-survey and post-survey to the final survey of a standard deviation of 0.548. This shows that there was an increase in providers' confidence levels in discussing the HPV vaccine and HPV with patients 2 months following. And again, patients are more likely to, the ones that return surveys were more likely to initiate the HPV vaccine series after discussing with their provider. The quality of my data, the credibility, all surveys were completely anonymous. Provider surveys were also collected by computer to avoid any risk of human error. Dependability, there was repeated patterns of data consistently. Transferability, the study and its interventions are transferable to other facilities. There's also ample opportunity for future research for interdisciplinary collaboration to increase HPV vaccination compliance rates. Collaboration with dentists to discuss how they can implement a protocol to aid in improving the HPV vaccine compliance rates is crucial due to the increasing rate of HPV-related oropharyngeal cancers. And validity, a subject expert reviewed, edited, and approved instruments to establish content validity as well. Ethics in human subject protection. No exposure to human rights were violated. All surveys were anonymous. The researcher does not know which providers or patient data is represented in data collection. The data is stored on a password-protected computer that is located in the researcher's office. The author of the project will be the only person with access to the password in the office, and all collected data for the project will be destroyed at the completion of the study. Timeline. The pre-survey, educational in-service, and post-survey took place on June 20th, 2021, and lasted approximately 15 minutes from start to finish. Providers distributed patient packets that contained the survey consents and returned envelopes where they would be sent back to the clinic over 2 months. The patient data collection stopped after the 2 months, and 26 patients' surveys were returned. Upon completion, the patient data collection, the final survey was sent to the providers, where they completed it at the privacy of their own computer and submitted it anonymously on August 20th, 2021. Limitations to this project. Unfortunately, there were multiple limitations to this project, the largest being the lack of participants and the small sample size. Small sample size of healthcare providers that participated is due to the small size of the clinic. It's very small. The study also kind of was in the middle of the COVID-19 pandemic. So as a result of that, the patient census was slightly lower. There was time restraints with patients, and so providers didn't necessarily want to be in a small clinic room face-to-face with patients for longer than what they technically had to be, just to keep them at a lower risk of spreading or getting COVID-19. And the COVID vaccine compliance became the top priority during that time. So during that time, if they were going to choose to discuss any type of vaccine, obviously they would choose, rightfully so, the COVID vaccine. Another limitation of this project is not including patients older than 26. The FDA has approved the HPV vaccine to be given to individuals between the ages of 9 and 45 years old, but the CDC does not recommend the HPV vaccine to individuals over the age of 26. CDC states that most people over the age of 26 will not benefit from the HPV vaccine, but refer to their healthcare provider to discuss the HPV vaccine and if it's eligible for them, or if it's right for them. And to slightly kind of go back, here are some of the results of the returned patient surveys as to why or why not they are more likely to initiate the HPV vaccine. There was multiple misinformation. They didn't know, uninformed, but if they were more likely to initiate the vaccine, some of the no's were kind of interesting. Married, that some just don't want it. Sometimes you just can't. But also, almost 27, the information sheet says that people over 26 don't usually benefit from it. But another one that is very common is that a lot of people don't think that the HPV vaccine is for females and males. So there are a few in there that say that they didn't realize that it was even for men, and that's why they didn't know they could get it. And my conclusion, so after 2 months of increased provider communication covering this topic, providers became more confident in discussing the HPV vaccine and recommending the series. I think this kind of just shows that it does get easier with time, and your confidence does improve the more you do things, as with everything with life. And increasing provider communication increases the confidence in discussing these things. And here are my references. Thanks so much.